First of all, I would like to thank the organizing committee, Professor Kreins, for inviting me here to give this presentation on what is probably my favorite topic until now. So when I was asked to talk about cryoablation of atrial fibrillation, today cryoablation of atrial fibrillation should be changed to cryoballoon ablation of atrial fibrillation, because nobody even thinks of performing a focal cryothermal ablation on the left side due to the length of the procedure this would carry with. So I guess I have to. Okay, so you talk about cryoballoon ablation, but you also talk today about second-generation cryoballoon, which is actually a technological revolution if compared to the first-generation cryoballoon, which already was giving comparable outcomes to point-by-point ablation with radiofrequency. Now, I just subdivided my presentation in a few chapters, and I'll try to be as synthetic as possible. So, as for acute outcomes, let me just show you technologically the differences between the first and the second generation cryoballoon. So as you can see, let's say that the most important panel would be, the laser would be this. The most important panel would be this. So this is the first generation cryoballoon. As you see, the white area corresponds to the coldest area on the surface of the balloon and corresponds actually to an annular shape. If you compare it to the hemispherical shape of the coldest area with the Arctic front cryoballoon, so you see that it's significantly wider area of lesion. Moreover, if you look at a transversal coupe of both balloons, what you can see is these are corresponding to the jets that are positioned and are positioned on the catheter itself and are irrigating cryorefrigerant, have been doubled in order to offer a more homogeneous freeze on the balloon surface. This is cryothermal paper. You can clearly see the difference between both images, whereas the deep blue corresponds to the coldest areas on the surface of the balloon. And as you can see, you have 4 areas with in the first generation cryoballoon versus a much more homogeneous image with the Arctic front advanced with the second generation cryoballoon. Again, just to summarize these ideas that cryoballoon users know very well, again, you know that the cryoballoon is based on getting occlusion of the pulmonary vein. It's actually an anatomically based approach to PVI. Now, the occlusion is the best indirect parameter to guarantee isolation. Now, what you see here is probably, if you would inject contrast, you would have occlusion with both the first generation and the second generation balloon. But in the case of the first generation balloon, what you would probably have is an area of suboptimal freezing in the interpulmonary carina that we all know is extremely important in terms of triggering atrial fibrillation. Now let's come to what the literature has just said. So the second generation, as you have seen, cryoballoon has come with technological improvements which have revolutioned the procedure in my eyes. But early animal studies conducted on dogs from the Montreal group showed that actually the tool was extremely powerful. So powerful that if you looked at these dogs which had been sacrificed 30 days after a cryoballoon ablation, what you actually saw is that if you were giving more freeze, not only were the veins both isolated either with 2-minute freezes than with 4-minute freezes, but if you were exaggerating with the freeze, if we were exceeding with the dosage time, you were seeing a PV stricture in a significant number of veins. That means stenosis. So we were dealing with a more powerful tool. This comes from Medtronic again and from the group in Phoenix. And again, it has always been thought that, the cryoballoon was not offering circumferential isolation, at least on the long run. But if you compare, again, these dogs, what you see is that in 3 out of 5 dogs with the first generation cryoballoon, you could still appreciate permanency of isolation in all veins. Whereas with the second generation balloon, permanency, independently of the diameter, because it comes in 2 diameters, a small diameter and a large diameter, with the second generation cryoballoon, 5 out of 5 dogs and 5 out of 5 dogs with the 23 and with the 28 millimeter cryoballoon respectively had all the PVs isolated at 1 month gross anatomical study. So these were anatomical studies. What happens in human beings? Well, this was the first study which compared the outcomes between the first generation cryoballoon and the second generation cryoballoon. And what was immediately leaps to the eye is that the procedure duration was significantly shorter with the second generation cryoballoon, and this is a group of Frankfurt, which is a high volume center for this technology. The fluoroscopic exposure was also significantly lower, and the possibility of seeing real-time isolation was also much higher in the second generation balloon and occurred faster. The veins were being isolated faster with the second generation balloon because it's a more powerful tool. This again is, well, I showed this because it's, I've seen this morning, it's mainly, the Congress is mainly axed on epicardial procedures, where anyway, this was published by Professor Pizon, which is currently busy with a very interesting case, and this is an epicardial view of an ablation with a first generation cryoballoon. And what you see is this is extracardiac ice formation. And if you really look very closely, you will see that there's this little whitish area. So hypothetically, this is probably the area where the jet was touching the wall of the PV. And these were areas of suboptimal lesion, which probably were more prone to reconnection later on. This was published by our group, and as you see, the image is distinctly different. This really looks like a globe of ice. It's much more extending proximal distally, and of course, you have no areas of suboptimal lesion, and it's just a blob of ice which is forming around the vein. So what about 1 year follow-up? What can we tell our patients with when these patients, when your patients, when you propose them a cryoballoon ablation? So this was, I think, the first study that came out from our group on 1 year follow-up. We analyzed 42 patients with the paroxysmal atrial fibrillation. And at 1 year follow-up, oops, sorry, how do I go back? Can you go to the previous? Thank you very much. What you can see that after a single procedure, 83% of patients were free of atrial fibrillation. We know that freedom of atrial fibrillation, at least they did not present atrial fibrillation anymore, whereas they were having asymptomatic episodes or not. This of course will remain unknown. But 83% of these patients were free of symptomatic atrial fibrillation and did not present any tracé of atrial fibrillation on the follow-up. This data was actually confirmed by the Hamburg group. In this case, they also included a third of their patients were early persistent atrial fibrillation. And after a single procedure, 80% of these were free of atrial fibrillation. Again, this is a paper coming from our group. We compared actually the outcomes between the last 50 patients with the first generation cryoballoon performed in our center and the first 50 patients with the second generation cryoballoon. And what we saw is that after a single procedure, 66 versus 84% of patients were free of AF. So the second generation cryoballoon was significantly better in terms of 1 year outcome if compared to the first. Again, this was confirmed by the Frankfurt group, which actually showed more or less the same results. I swear we didn't talk to each other. But I mean, we had 66, they had 63.9, whatever. But I mean, the results were absolutely the same. So what is interesting is that results, at least on the paroxysmal atrial fibrillation side, tend to be relatively reproducible. What about complications? Now, you know that cryoballoon ablation is associated mainly with one typical complication, which virtually only appears during balloon-based technologies, which is the phrenic nerve palsy, right-sided phrenic nerve palsy, although left-sided phrenic nerve palsies have been demonstrated also to be there sometimes. This was a paper we published in Heart Rhythm, and we compared the incidence of phrenic nerve palsy between our last patients with the first-generation cryoballoon and the incidence of phrenic nerve palsy with the first-generation balloon. And what we saw, we were actually quite scared that in the first 20 patients, in the first 20 patients, we had a huge amount of phrenic nerve palsies. So we were scared. We were actually about to stop because we were clearly dealing with something that was significantly more powerful than what we were used to. But again, we needed to do something different in the right-sided veins in order to avoid this complication, which usually is transient, but it can be persistent, and patients can be symptomatic. So this is just an example of what you can do to get to the more proximal side of the PV ostium. So what we actually do is we wedge the balloon inside the PV. We inject some dye. We then pull back until a small leak is appreciated. Now, when the balloon is inflated, typically the 28 millimeter balloon, the diameter of inflation is just 26.5 millimeters, and the internal pressure is around 2 to 3 psis. When you start freezing, the balloon grows to its actual 28 millimeter diameter, and the pressure inside grows to 17.7 psis. What does that mean? That means that you have a stiffer and larger balloon, which is probably more difficult to advance towards the phrenic nerve's course. Not only, but this augmentation this increase in volume and usually closes the leak without further need of advancement. It has also been seen, especially by German groups, that the esophageal temperature should be monitored with the second-generation cryoballoon. That's what they concluded, because it does create more esophageal lesions if compared to the first-generation cryoballoon. Either the Hamburg group than the Frankfurt group actually agreed that more or less you should be very careful when the temperature gets down in the esophagus to 12 degrees or roughly 10 degrees. Again, this poses the idea of what about shortening the freeze-thaw cycle duration? Do we need to reduce the dosage? Because we're dealing with something that's significantly more powerful. We're dealing with an area which is extremely thin around the PVs. It probably approximates 2 to 3 millimeter thickness. So do we need to give all this power in order to isolate permanently the PVs? This was actually the first and only, well, the first dosing study that was an only dosing study, as far as I know, with the first generation cryoballoon. So what did the Hamburg group do? They actually compared patients having undergone after the isolation, after the freeze that led to isolation, 1 bonus freeze versus 2 bonus freezes in the same vein. And what they saw is this: application of 2 freeze-thaw cycles when compared to 1 freeze-thaw cycle following isolation, of course, did not result in improved clinical success, but was associated to a higher complication rate. So 2 freezes more were not needed. Again, I think we should a bit revisit the idea of this freeze-thaw-freeze approach, because as you can see, the minimum recommended duration of 4 minutes was derived from clinical studies that were published 15 years ago with different refrigerants, with different tools, They were on different arrhythmias also, because they were mainly addressing AV nodal ablation. So this concept of a minimum recommended duration of 4 minutes and of giving 2 freezes has not been re-challenged despite major innovations. So we said, why shouldn't we try and see what happens if we start reducing the freeze time? Now, this was published in JICE in 2013, and we currently perform in our lab a single 180 second freeze, provided the vein is isolated within that freeze. We're now also analyzing predictors of what can ensure us the permanency of isolation. But anyway, what we saw is that we analyzed a total of 52 patients. In the first 24 patients, we were giving a bonus freeze after isolation, and no bonus freeze was given in the last 28 minutes. Now, I accept that the major limitation of this study is the fact that the follow-up is only barely 6 months. But it does give an idea that, first of all, a single freeze is enough to isolate the majority of veins with the second-generation cryoballoon. And moreover, during this first 6 months, of course, we did not calculate a blanking period, because it would have been a follow-up just of 3 months then. 82% of patients did not experience atrial fibrillation, and there was no difference between the single versus the second versus the double freeze group. I'm sorry for this slide; it's very ugly, but whatever. Again, we published our 1-year follow-up on single 3 minutes for the second-generation cryoballoon on heart rhythm. We had a total of 145 patients with a mean follow-up of 12 months. Freedom from AF, ATA, we also englobed flutter and anything, was 80% in this population. Persistent phrenic nerve palsy was present in 3.5, but what do we intend with persistent phrenic nerve palsy? We consider persistent phrenic nerve palsy when the patient gets out of the, steps out of the table. Actually, he's asleep, so is taken out of the table and still is exhibiting phrenic nerve palsy. So most of these actually resolve within the first days, months of the procedure. So in summary, this new balloon, because I mean I think we should forget the old one, has improved acute procedural outcome. There is a reproducible sync between high volume centers, single procedural 1-year success of roughly 80 to 84%. There are, of course, now I think there are different possible strategies. Are we going to base our dosing on real-time recordings? Are we just standardize the reduction of freeze? And are we still going to give a bonus freeze? This is a matter, of course, of research and discussion. I thank you very much for your attention.
Other questions? Harry?
Thanks very much. Very nice overview, really illustrative. My question is, do you use temperature measurement in the, I missed that maybe, in the esophagus?
We don't.
Okay, and but you do use the phrenic nerve stimulation during
Absolutely.
And what I always find so annoying, that is that you do this pacing, you see the movement, and then you see the decrease in the movement, you stop immediately, and still they go into phrenic nerve palsy. How do you explain that?
Well, I know how it can be prevented. I don't know how it can. I mean, so the phrenic nerve lesion is a Wallerian lesion, so you have the destruction of the axon, but if you stop in time, the myelinic sheath will stay intact. Mm-hmm. So that's the good news. There are various monitoring systems out there. The compound motor action potential is one. It's the electromyographical analysis of the diaphragmatic contraction, which can predict phrenic nerve. If there is a reduction, I think, of less than of more than a third in the peak-to-peak initial measurement, you probably are going to have palsy. So there is an impending palsy. We are now using a system which has recently been published by Justin Ghosh in Heart Rhythm, which is based on the analysis and the measurement of the central venous pressure, which is of course influenced by the diaphragmatic movement. So we simply position a pressure system on one of the sheets in the groin, and we analyze the peak-to-peak the peak-to-peak variation during diaphragmatic contraction. And if there is a reduction of more than 50% we stop, and the phrenic nerve continues to. With this method, in our last 100 patients, we had 0 even transient phrenic nerve palsies.
And you had to stop several times?
We had to stop, yes. We did stop several times, yes.
I just want to ask if this 5%, which is quite high, I think, was permanent. That is, they persisted after 1 year, or was it just...
No. Yes, that's also a very good question. No. Only one patient in our series with the second-generation balloon is still persisting.
Yeah, because that's an important figure.
Absolutely.
And there's one study showing, actually, that if you ask the patient to breathe regularly during the application, then you will detect this phrenic nerve palsy earlier than if you pace.
Mm-hmm. Yes, well, yes, it's actually based on SCOPY, I think. It's just, is it the SCOPY one? No? I don't know. But anyway, our patients are asleep, so we cannot ask them to breathe. But this new, your point is right. I think there are gargantuous efforts in trying to find the right monitoring strategy to avoid this complication, which is typically associated to this kind of procedure. But still, it does occur. We find the central venous pressure very, very reliable, and we have seen our numbers of phrenic nerve palsy significantly come down.
Okay, that's extremely interesting. And gastric paresis, we have seen some cases which may be very ugly. How can you prevent that if you do not monitor in the esophagus?
That's very difficult to prevent, in fact. I don't even know if you can prevent it. There is a case that I know, an Australian patient who was put on liquid diet for a while. I guess my question is, we have some patients in the following days after ablation who are actually saying that they have a bit of uneasy feeling when they eat, but then it goes away. Now, my question to you: did you ever see a persistent gastroparesis in your center, and what can we do about it? Because we didn't have this experience.
I think we had one, and I know of one other patient who resolved after, I think, 2 weeks or something.
Okay.
And in that patient, PPIs again were very effective. But I think we had one patient.
I know of 2 persistent cases, one here, and also another center in the Netherlands who also had a persistent case.
Did this occur during? I know it's impossible to know. It would be interesting.
It's the second generation.
No, this probably, but it has also been described with the first generation.
Yeah.
But do you think this could be dosage dependent also?
I don't know.
Or just unluck dependent because the vagus is passing?
I remember the case, but we tried to identify what we could have prevented. But I know we looked at CT images, if there's a relation between the morphology and the distance, but it didn't help us.
Okay.
So one question about the phrenic nerve. What is your order of ablation? Because the risk is highest in the right superior. And if you then have phrenic nerve palsy, you stop the procedure probably. What's your order?
Well, you just answered by the question. Yeah. So we go for the RIPV and then the RSPV. Well, that's very important. I think everybody should do this. Yeah. I mean, even if phrenic nerve palsies have been described with the second generation balloon, I think more often than with the first generation balloon. I know that Wynne Davies demonstrated the first RIPV, well, the first palsy during ablation during RIPV. It should be aggressed before. And you're fresher, and it's tougher to occlude.
Yes,
So.
yes. Okay. Thank you.
Very last question. I was curious just about the difference you shown between your study and the parallel study about freedom from recurrence. Can you just comment?
I'm so, I didn't understand the question. I'm sorry.
You shown the difference. You
Yes.
said that you had the same results than a parallel study you shown today.
Yes.
But we saw a difference in freedom from recurrence, 63 versus 84, with a significance of 0.008.
Yes.
Just a comment about that. Why you justify this difference?
So that's just to put things right. What you're referring to was the outcome from the first generation compared to the second generation cryoballoon. So these are two different devices. So what we did in that study was simply to compare the last 50 patients that we did with the first generation device and the first 50 patients with the second generation device. And the significant difference is probably due to the fact that the second generation device is simply more performant, offers a significantly more homogeneous lesion. So this probably guarantees better outcome in terms of permanency of pulmonary vein isolation.
Okay, thank you. I misunderstood. Okay, any question? Thank you very much. Thank you.